Dear professors and colleagues who follow the Academy of Kidney Disease and Transplantation channel, it's my pleasure today to speak about phosphate control in chronic kidney disease and dialysis. It's an updated data. So to start with, what is about the evolution and epidemiology of hyperphosphatemia? I think this is a very famous figure showing that with development of chronic kidney disease, we have pathophysiology through increasing hormones, principally parathormone and FGF23. The aim of these two hormones is to advocate phosphate excretion by the kidney because kidney is the main organ for phosphate excretion. They succeeded for a period of time, and ultimately, with the advancement of chronic kidney disease, hyperphosphatemia may develop. The increase in beta H through hyperparathyroidism, maybe hyperplastic, then may extend to nodularity, and with the expense of clinical manifestation and vascular calcification. So this is a very important point. If we go to the international publications and the racial differences to see the incidence of hyperphosphatemia, this is the value color codes, reflects the serum phosphorus less than 3.5 milligram per deciliter, between 3.5 to 4.5, and then higher level from 4.6, 5.6 and above 7. And you can see here the color in different countries. For example, in USA, if you go to the color, the green color, 5.6 to above 7, this is 33%. This means above 1/3 in the United States have significant hyperphosphatemia. And you can go to every country in this slide to know the distribution of hyperphosphatemia. Regarding phosphorus above 6 milligram per deciliter, which is severe hyperphosphatemia, you can find the good percentage of number of patients everywhere having severe hyperphosphatemia. Why? Hyperphosphatemia in chronic kidney disease and dialysis is important. Why? Because all of us are aware with phosphate toxicity since a long time. The hyperphosphatemia, phosphate is considered as a uremic toxin. And more importantly, hyperphosphatemia is associated with dysfunction of many organs, including kidney, parathyroid gland, bone, and vascular system, and even here, direct cellular toxicity. This is, and muscle problems leading to browning of adipose tissue and muscle atrophy. So all these are problems of hyperparathyroidism. What are the data from the update? This is one of important data. It is, yes, it is experimental animal model in male mice with 5/6 nephrectomy model of chronic kidney disease. The authors found that the higher the serum phosphorus, the more the impairment of testicular function. Yes, it is animal model. From human studies, addressing cognitive function by mini mental state examination showed that the higher the serum phosphorus, the impairment of the cognitive function. So the hyperphosphatemia is associated with abnormal cognitive function in human. Regarding residual kidney function, I think this is an important issue that we strive for keeping some residual kidney function in dialysis patients. This is the number of patients, 13,700 patients, including in this study. And when they assessed the hyperphosphatemia, the more the elevated serum phosphorus is, the fast decline of residual kidney function and loss of residual kidney function. It is very bad because we like residual kidney function to allow flexibility in drinking and in nutrition of the patients on dialysis. And if we look at this subcategorical analysis, we have here serum phosphorus less than 3.5, up to 5.5, or if it is above 5.5. If serum phosphorus is elevated above 5.5, this is associated with rapid loss of residual kidney function, irrespective to the demographics of the patient, the age, serum albumin, urea clearance, ideal body weight, a lot of demographics. The higher the serum phosphorus above 5.5, the rapid loss of residual kidney function. So the best serum phosphorus in dialysis is to keep it between 3.5 to less than 5.5 milligram per deciliter. Male is not a male gender. Male is major adverse limb event. What is this? It is a surrogate marker for the occurrence of the peripheral vascular diseases. So this is a 10-year outcome of the Q cohort study showing the quartile of serum phosphorus in this range. And what do you see? If we have very low serum phosphorus, this is bad, as you see here. But the severe hyperphosphatemia, the higher the percentage of major adverse limb event. So the severe hyperphosphatemia is associated with limb event, and to be put in mind. A very interesting data correlating the issue of hyperphosphatemia with cardiovascular mortality in a study including more than 17,000 hemodialysis patients. This is very interesting. Why it is very interesting? Because they evaluated serial values of serum phosphorus and then evaluating the change, either no change or increased from 0 to 0.5, from 0.5 to 1, from 1 to 2, or above 2 milligram per deciliter increase in serum phosphorus. And they correlate this change in serum phosphorus with cardiovascular mortality, as you see in the result of this figure. If we take it one by one, this color reflects the area under curve of serum phosphorus change above 4.5 is above 2, and this is the from 1 to 2. So and this is from above 0.5 to 1. What do you see? All major cardiovascular events and congestive heart failure are increased if there is increase of serum phosphorus by the time, especially for the group with severe hyperphosphatemia. Area under curve is more than 2, above 4.5 during the 6-month evaluation of serum phosphorus. Cardiovascular death, the same. The higher the serum phosphorus and the increase in area under curve following serial monitoring of serum phosphorus, the higher cardiovascular death. All-cause mortality, you see here, if area under curve is above 2, the all-cause mortality is significantly high, and even non-cardiovascular death, there is a trend, but it's not significant as you see here. So this study shows that hyperphosphatemia, especially high value and increasing through the serial follow-up, is associated with increased mortality. So how to control serum phosphorus in dialysis patients? Before I'm going to explain the management approach for hyperphosphatemia, it's important to clarify the key players of hyperphosphatemia. As I mentioned, kidney is the main organ of excretion, so loss of kidney function and is associated with impairment of renal excretion of phosphorus. Absorption from the gut, from dietary phosphorus source. So we should pay attention to what we eat. Bone resorption releases stored phosphorus. So these are the three key players for hyperphosphatemia. Loss of kidney function by the time and advancement of CKD, increased phosphorus bioavailability from the diet, and bone resorption. These are the key players. This is why the new paradigm in the management of hyperphosphatemia is focusing on 3 Ds: diet, drugs, including phosphate binders and drugs that targets the phosphate absorption from the intestine, and lastly, for patients on dialysis, to optimize dialysis status. And according to the last and the updated KD guidelines for CKD and MBD, we need phosphorus to be reduced toward the normal range in dialysis patients. So it is important to be considered all these domains. The first part of the management is diet, and I'm going to highlight the importance of hidden sources of phosphorus. This is the diet. And the bioavailability. Bioavailability means the percentage of phosphate absorption from the intestine to the blood. What do you see? The plant source from grains, legumes, and nuts of phosphorus, the absorption is ranging between 30 to 50%. This means that bioavailability from plant sources is limited. Why? Because phosphate is bound to phytate and we cannot digest phytate. So the plant diet is important to avoid severe hyperphosphatemia. Animal sources are important to avoid malnutrition, and the animal source meat, cheese, and fish. The bioavailability is different from food to food. It ranges from 60 to 90%. This is an organic source of phosphorus. To put in mind, even we can, by the help of expert in diet control, we can take the requirement of proteins with less phosphorus, because proteins are classified into low phosphorus and high phosphorus content. The most important issue is organic sources of phosphorus are associated with the highest bioavailability. And for inorganic additives, soda, prepared foods, canned foods, all these are of no significant beneficial effect and even maybe hazardous. So the absorption is 90 to 100%. This is why we should educate our patients to control their behavior regarding soda, prepared food, canned food, and to depend upon fresh prepared foods. To put this in mind. Regarding dietary protein sources and the phosphate level in patients on hemodialysis, this is a very recent study, confirmed that we can, even if we take a portion of the diet from plant sources, because we can depend on plant, increasing the fraction of plant diet in dialysis patients without compromising the nutritional status of the patients. A very interesting and important data to put in mind. What about hidden phosphorus? Hidden sources may be in the food additives, including pH regulators, stabilizers, and flavor color enhancers. All these may contribute up to 1/3 of dietary phosphorus, and all of these can be prevented. Dietary phosphorus in the form of food additives has roughly doubled from 1990 to 2005, and approximately 50% of food in the United States supermarkets have phosphorus-containing additives. I think this is one of the targets to be modified and to be considered and to concentrate on this issue. A second important aspect is poor labeling of phosphorus content in the diet. I think if we take the action against both additives and poor labeling, this may improve everything. What about the current updated KDUQI clinical practice guidelines for nutrition, especially for serum phosphorus control in adults with chronic kidney disease stage 3 to 5 dialysis? The guidelines recommended adjusting dietary phosphorus intake to maintain serum phosphorus levels in the normal range. And dietary sources in adults with different stages of CKD and even post-transplantation, it is reasonable when making decisions about phosphorus restriction treatment to consider the bioavailability of phosphorus sources, animal, vegetable additives So to stop additives, encourage vegetables, and to moderate the animal or select the animal proteins which is lacking some phosphorus. Another important source for hidden phosphorus. This is a very interesting article showing the different forms. I'm not speaking about neutral phosphate capsules or glucophos as direct sources for phosphorus. No, I'm speaking about antihypertensive and diabetic drugs that may include phosphorus, and the phosphorus content is not highlighted in the pamphlet of the drug. For example, these are different drugs. Amlodipine 10 milligram tablet includes 120 milligram phosphate, to put in mind. And we can even, if this is, I think this is a call for all industrial companies to write and to add phosphorus contents of the drugs into their pamphlets. And if the patient is treated with new drug and you find increased serum phosphorus after this drug, we may suspect the presence of phosphorus content within this drug. Targeting phosphorus absorption. This is, I think, the coming figure is important because coming out of the pits, and I'm going to explain what's meant by pit in this cartoon. This is the intestinal cell. For phosphate absorption from the intestine, we have two pathways: transcellular pathway through sodium phosphate to be transporter, BIT1 and BIT2. And this is the transcellular pathway for phosphate absorption. And all of these transporters are active transport. What about the passive transport through paracellular between the cells? This is controlled by sodium hydroxide exchanger. Why it is important? Because I think if we memorize this slide, then we will know how to handle serum phosphorus. Either manipulating the diet as a source for phosphorus, or using phosphate binders that bind the phosphorus and to reduce their bioavailability. And lastly, to target the intestinal absorption through inhibiting this transporter. And you have these drugs, nicotinamide and others, that target this one. And this is a nice molecule, new molecule, can target all the transcellular transporters. And for the paracellular absorption of phosphorus, tinabanor, through inhibition of sodium hydroxide exchanger, can inhibit paracellular pathway. So this, I think this is a panoramic slide, a very important. I'm going to explain all the different drugs used for control of phosphorus. To start with, phosphate binders. There are important 5 questions to be answered. Can phosphate binder be taken without food? The answer is no. Either they are taken with food or immediately before eating. Because if we take phosphate binders away from food by many hours, this will be a problem, leading to increasing side effects and reducing the capacity of phosphate binders to bind phosphate. The second, why would a dose be missed? This is one of the targets to be addressed, how to encourage patient adherence to treatment. If a dose missed, should it be skipped until the next meal? We should encourage the patient to be adherent to treatment, but I'm not going to advise the patient to double the dose of phosphate binder on the next occasion. Should chewable tablet, such as over-the-counter calcium carbonate, be chewed or swallowed whole? If the tablet should be chewed, it should be chewed. With the exception of saccharopheric oxyhydroxide, it can be splitted. I'm going to mention this in a minute. Should phosphate binder use be personalized? Sure, it should be personalized according to the patient demographics. So these are important 5 questions. What are the current members of phosphate binders? I think this table summarizes the different members of phosphate binders. I'm going to comment on each binder. So calcium carbonate forms insoluble calcium and phosphorus complexes and reducing the phosphorus bioavailability. Potential advantages is this drug is cheap, inexpensive, available over the counter, and with long-term experience of their use. The potential disadvantages include hypercalcemia, because it is calcium carbonate, risk of vascular calcification, gastrointestinal side effects, and low turnover bone disease. The forms: chewable tablets, capsule, liquid, and gum. The dose of consideration: 40% of elemental calcium, 200 milligram per 500 milligram total dose. So this is the binder equivalence, 0.75 for 750 milligram tablets. So this is the pharmacology of the first binder. Regarding calcium acetate, forms insoluble calcium and phosphate complexes, the same like calcium carbonate, inexpensive, readily available, long-term experience. This is the advantage over calcium carbonate. Calcium absorption is less than calcium carbonate. But the problems are hypercalcemia, risk of vascular calcification, gastrointestinal side effects, and low turnover like calcium carbonate. They are available in capsule and liquid, and this is the percentage of elemental calcium, and this is the regarding the phosphate binder equivalent. So just to look at the values, and that's it. Regarding lanthanum carbonate, forms insoluble metal and phosphate complex. The major advantage is calcium-free phosphate binders, but this drug is expensive, unclear risk for metal accumulation, gastrointestinal side effects, and no long-term data. Chewable tablets and powder, and this is the dose consideration from 500 to 1,000 milligram 3 times per day. And this is the equivalence. This is 1 for 500 milligram tablets. I think it's important to look at the equivalence to know how to go. For sevelamer hydrochloride, exchange chloride for phosphorus. It is calcium-free, like lanthanum, has pleiotropic effects, and may reduce vascular calcification. But it is expensive, has gastrointestinal side effects. Chloride may lead to metabolic acidosis, is why we should discourage the use of sevelamer hydrochloride. Limit fat-soluble vitamin absorption. This is another important point. The dose is between 800 to 1,600 milligram 3 times per day. The maximum dose is 13 gram per day. And this is the equivalence for phosphate binding for 800 milligram tablets. For sevelamer carbonate, it is the same like sevelamer hydrochloride, but exchange here chloride, here exchange carbonate for phosphate. Calcium-free, pleiotropic effect, no metabolic acidosis, and this is advantage over sevelamer hydrochloride. And if we use sevelamer, it's better to use sevelamer carbonate. It is expensive with gastrointestinal side effects and limit fat soluble vitamin absorption. A tablet and powder, and this is the dose, the same like this one, and the maximum dose is 14 grams per day, and this is the equivalence for phosphate binders. Saccharoferric oxyhydroxide, exchange hydroxyl for phosphorus, calcium-free, lower pill burden, and this is very important because high pill burden even may lead the patient to stop necessary medication like ACE inhibitor and others. Expensive, with associated with gastrointestinal side effects, interfere with oral levothyroxine. Long-term side effects are known, and clear risk of iron accumulation. Chewable tablets, and nowadays there is another form which is split, 2.5 gram 3 times per day, 500 milligram iron per 2.5 gram tablets. Maximum dose is 6 tablets per day, and this is the potency of phosphate binder. As you see, it is very nice. The ferric citrate forms insoluble ferric and phosphate complexes. Calcium-free raises iron stores and hemoglobin, decreases the need for iron therapy and the ESA usage. Expensive, gas on side effects, long-term side effects unknown, unclear risk of iron accumulation present in tablets. This is the dose, and this is the phosphate binding equivalence. I'm sorry because this is a very basic table, but I hope that you can fix the video and read everyone in details if you want to use. Just to show some studies. This is the study comparing the sevelamer hydrochloride or carbonate to calcium acetate, trying to address cardiovascular outcomes of calcium-free versus calcium-based phosphate binders in patients 65 years or older with end-stage renal disease requiring hemodialysis. We are expecting that calcium-free will be associated with better cardiovascular outcome, but as you see from this figure, there is no difference between both calcium-based or sevelamer. This means that the evidence is lacking. This is not a randomized control trial. This is an observational study, but it is negative, no significant difference between sevelamer and calcium acetate. This is another important caution for the use of sevelamer. This is all the patients, and this is sevelamer non-user, and the 41%, 172 use the sevelamer. And the main message here is sevelamer reduces vitamin K absorption and maybe indulged increasing oxyl sulfate, bicresyl sulfate, and other uremic toxins. So this is, I think this is one of the disadvantages and the problems of sevelamer. Regarding ferric citrate, this is a recent meta-analysis including 16 studies confirming the efficacy of ferric citrate plus enrichment of iron stores. The main problems are diarrhea and feces discoloration was significant. Both of them were significantly higher with the use of ferric citrate. I'd like to explain this concept because it is concept and it still needs further clarification. As you see here, the hyperphosphatemia and iron deficiency or iron deficiency anemia, both of them are significant stimuli for fibroblast growth factor 23, which is associated with cardiovascular problems and kidney problems. If we use ferric citrate, it will block phosphorus because it's a binder to phosphorus and correct iron deficiency. So the concept is if we use this drug, ferric citrate, it may lower not only phosphorus, but as well FGF23 with expected potential. And again, it needs further evaluation in studies. Regarding saccharoferric oxyhydroxide, this is a study. Although the number of patients are limited, here 57 patients, in the control is 48 patients. Both of them used phosphate binders. And this is the serum phosphorus. The lighter color means that the phosphorus is here in this range, less than 5 milligram per deciliter. Here in saccharoferric group, it is significantly higher, 92% after 3 months, and this is the baseline, 62%. So using the saccharoferric oxyhydroxide was associated with significant reducing of serum phosphorus. And here in comparison to other phosphate binders, this means that starting with 83 and ending with 83, this means no significant change, but the use of saccharoferric oxyhydroxide was associated with significant success in controlling serum phosphorus. The most important point for me is the number of the pills. Here, after 3 months, the patient used 2.3 pill in the saccharoferric oxyhydroxide group, while in the other phosphate binder still using 5.6 or 6 tablets or from the pill. So the major advantage of saccharoferric oxyhydroxide is its efficacy with reducing the number of pills used for treating. And even this is the patient chooses, because when we improve the adherence by shifting from chew to split and swallow, as you see here, and the acceptance before the change, 50-50, but after the splitting and to be swallowed here, the adherence is improved significantly and accepted by the majority of people. So saccharopheric oxyhydroxide, the profile of this molecule is very nice, but we are waiting further availability and testing in many studies. Moreover, this study addresses the neuroprotective effect of saccharopheric oxyhydroxide in rat model of chronic kidney disease. It may be through reducing FGF23. What is this? PT20. It is a combination of ferric iron oxide and battery ligand adipic acid. The rationale of this molecule is to enhance the phosphate binding capacity in a very small and very few number of pills. This is the randomized double-blind placebo-controlled dose ranging phase 2b study in patients with hemodialysis-dependent chronic kidney disease. As you see, in comparison to placebo, here the intervention 3 per day, different dosages of PT20. In comparison to placebo, there is significant reduction of serum phosphorus, especially with the larger dose, as you see, in comparison to placebo, and with tolerability, excellent tolerability. So we are waiting further studies in this new molecule. To look at the phosphate binders in a panoramic view, as shown in this very nice article. A lot of confounding pathways are there in all studies and clinical trials assessing phosphate binders. And this is an important aspect that interfere even with patient-centered or patient preferences. So the studies are depending upon surrogate outcome and with a lot of confounding. And this is the problem is calcium-based is associated with vascular calcification biochemical parameters that may lead to vascular events. The blue line is reflecting some beneficial effects of phosphate binders, reducing inflammation, cholesterol, improving anemia management. It may be correlated positively with the cardiovascular outcome. And the purple one is the adverse drug effects that may even interfere with the outcome badly or negatively. So at the end of the day, we still search for the optimum phosphate binding. From binders to absorption, if you remember the paracellular pathway of phosphate reabsorption through the sodium hydrogen exchanger dependency, tinebanor is the drug that inhibits sodium hydrogen exchanger in the intestine with inhibiting paracellular pathway. In phase 3 trial in hemodialysis, as you see, tinebanor significantly reduced the elevated serum phosphate in patients with hemodialysis with hyperphosphatemia. So this is the tinebanor 3 milligram BID, 10 milligram and 30, as you see, reduction of phosphorus even after withdrawal period. Here in comparison to the placebo, here is still the rise of phosphorus is delayed. So even after stopping of tinebanor. So I think this is a promising drug, but we need further studies because this is the number of patients, 219 studies. We cannot take evidence-based medicine from a study, including this number of patients. So we are waiting further studies. But this is one of the important notion to be considered, that FDA approves tinebanor for treating irritable bowel syndrome away from the CKD and dialysis and irritable bowel syndrome in general with constipation type. The question why? Because the major side effect of tinebanor is diarrhea. So they use this side effect for treating constipation in irritable bowel syndrome. Again, tinebanor safety is not confirmed in children, and it seems that there is a problem in safety in these patients, so it is not to be used for children until we have studies. Regarding the combined trial, this is a very interesting trial because it addresses combination of phosphate binder lanthanum carbonate with nicotinamide, which inhibits sodium phosphate transporter within the transcellular pathway of phosphate reabsorption. And I was waiting the results of this randomized controlled trial, fantastic study, because it includes, this is nicotinamide active, lanthanum active, both of them are active, nicotinamide active, placebo, lanthanum, nicotinamide placebo, lanthanum active, nicotinamide placebo, lanthanum placebo. So this is a very strong design. And I was eager to know the results of this combination, and I was expecting the beneficial effect of this combination. However, unfortunately, the results of this randomized study was negative, and adding nicotinamide to lanthanum carbonate doesn't add any appreciable significant effects. This may be due to tolerability issue of nicotinamide, but the hypothesis is still valid to target both binding and absorption. I think it is a good, but we are searching for more safe, more palatable drugs to be used. Regarding EOS789, this is a new molecule targeting all the BITs, sodium phosphate transporter, type 2B, BIT1 and BIT2. It is band transporter inhibitor. In the animal model here, the drug provides beneficial effects against hyperphosphatemia and its complications by the strict restriction of serum phosphate. Very nice in animal model and promising in phase 1 human studies, and we are waiting further evidence. Here, I would like to confirm that treating hyperparathyroidism is a part of the domain of secondary treating hyperphosphatemia is within the spectrum of secondary hyperparathyroidism. And this is one of the videos that I recommend you to go through. It is more than 2 hours, including discussions with experts. And if we just look at the relationship of hyperparathyroidism to phosphorus and the treatment of hyperparathyroidism and its impact on phosphorus control, vitamin D analogs are associated with hyperphosphatemia. So this is red color. But the using of calcium mimetic, either cinacalcet, etylicalcetide, and evocalcet, all these calcium mimetics are green color. This means that they are associated with a reduction of phosphorus. To put all this in mind. What about dialysis? This is a very interesting results table showing comparison of phosphorus removal between dialysis modalities. To start with, peritoneal dialysis, removal of phosphorus is limited by peritoneal dialysis. This is the first point. And for hemodialysis, the longer and the more the frequent of the dialysis modality, the better the clearance of phosphorus. So if you look at nocturnal long hemodialysis, 6-day dialysis, and each session is between 6 to 8 hours, this is associated with maximum removal of phosphorus from the body. So this is to put in mind. Sometimes if the patient has severe hyperphosphatemia while he is maintained on peritoneal dialysis, and after exhaustive techniques with the diet and etc., it is better to transfer the patient to hemodialysis for controlling of phosphorus, because hemodialysis is more competent. Messages from Malaysia. This is for patients on dialysis, and how the determinants are there of serum phosphate level among hemodialysis patients in Malaysia. Before I'm going to highlight this study, I would like to comment on this issue. Serum phosphate or serum phosphorus. Is there a difference between phosphorus and phosphate? Yes, there is a difference, although we use them interchangeably, but the serum phosphorus binds oxygen to be phosphate. And when we say that normal person needs 1 gram of phosphorus, this is the same as we say that this person needs 3 grams, because 1 gram phosphorus equals 3 gram phosphate. This is just NAB, not to be bottom mind. But here from the Malaysian message in hemodialysis patients, please look at this very nice study, because here I'm going to stress upon the multiple linear regression. Adequate dialysis is associated with a reduction of serum phosphorus. So if the patient is treated with dialysis, we should conduct adequate dialysis. Adherence to phosphate binder, to encourage adherence to phosphate binder is associated with reduction of serum phosphorus. The older age, the lower the serum phosphorus. Sleep duration, the adequate sleep duration, the lower the serum phosphorus. Diabetes is associated with higher serum phosphorus. Depression reduces serum phosphorus. Social support reduces serum phosphorus. So it seems that dialysis adequacy, adherence to treatment, and proper control of diabetes and social supports are beneficial to reduce serum phosphorus. The lack of depression is associated with increasing phosphorus. This doesn't mean that we should leave the patient to be depressed for the control of phosphorus, but to educate the patients toward adherence to treatment. What about the new paradigm, the new ideas and trials? This is all the nephrologists nowadays, like the sodium glucose cotransporter 2 inhibitors, after the results of the Credence trial and the DABA kidney, and we are waiting IMBA kidney. But to put in mind that the sodium glucose cotransporter 2 inhibitors may increase phosphorus, increasing beta H, FGF3, and reducing vitamin D. Although if these changes are minimal, I think we should follow them in further studies to put in mind. Another interesting point is the circadian rhythm of serum phosphorus. This is a control normal person. Look here, there is a great difference between the peak of serum phosphorus here at the time and here in the control. The question is, if we know this chronological manner or circadian rhythm, and we try to manage the patient at the peak of serum phosphorus, expected peak of serum phosphorus, does it make any difference? I think it needs further studies. This is one of important ideas. If we live in neighborhood of good food environments, so the effect of neighborhood food environment and socioeconomic status on serum phosphorus level for patients on chronic dialysis was addressed in this study that included 258,000 patients on chronic hemodialysis. The main messages and conclusion: neighborhood of food availability and socioeconomic status were not associated with serum phosphorus control. What is more important is knowledge about food, income, taste preference, and the lack of inclusion of phosphorus content in food labels might be more important issue than food availability in determining patient phosphorus level. And I think including phosphorus content in food labels might help patients adhere to a low phosphate diet. Very important. Patient education and food labeling. What about improve CKD and the rationale of this multi-center, double-blind randomized controlled trial? It is done in CKD before dialysis, trying to convince people to start treating phosphorus while serum phosphorus is still normal, to cut down the pathophysiology from earlier beginning. Does it translate into significant beneficial effects? Let us see. So this is a randomized controlled study. Don't forget the name: impact of phosphate reduction on vascular endpoints in chronic kidney disease, improve CKD. This is the patients on stage 3B from 45 to 30 milliliter per minute, estimated GFR, and stage 4 between 30 to 50. The number of participants are 278, and they were randomized into lanthanum carbonate and matched placebo. This is lanthanum carbonate, 500 milligram, thrice daily for 96 weeks, treating 138 patients and a placebo for 140 patients. What are the results? After 96 weeks, lanthanum carbonate didn't affect arterial stiffness or vascular calcification compared with placebo in CKD stage 3B and 4. And these are the tests done: pulsed width velocity, aortic calcification, serum phosphate, urine phosphate, intact FGF3, and PTH. So it is negative. This means that even using phosphate binder from the early beginning, before hyperphosphatemia, a normal phosphatemic CKD doesn't add much. To the extent that this is an editorial comment saying binder, blunder. Blunder means mistake or fatal mistake. Binder, is it binder or blunder in chronic kidney disease? I think the statement is we don't have a golden and magic bullet against phosphorus up to this moment. And there are still unmet needs, and unmet needs long-term trial in larger patients cohorts are needed for nicotinamide and tinepanor. It is still unclear whether tinepanor can improve phosphate control compared to phosphate binders. Information is also lacking as to whether tinepanor may also act synergistically when used in combination with phosphate binders. The potential synergistic effect of tinepanor or nicotinamide with phosphate binder remains to be fully understood and explored further in vivo studies, and this has not been evaluated yet in CKD patients. Long-term trials examine the effect of nicotinamide as add-on to phosphate binder are missing. Novel mechanisms of action that have a pathophysiological rationale to address hyperphosphatemia are missing. The mechanisms regulating phosphate control in healthy individuals is poorly understood, particularly how paracellular phosphate uptake occurs. It is poorly understood as to why ASCP 3325 has been shown to be effective in preclinical studies but ineffective in patients. This means that we are waiting further evidences for even new molecules. And there are a lot of unknown to be addressed. Don't forget, the major point is 3 Ds: diet, encouraging good diet, avoiding the ingredients and added issues, food additives, and canned. All these are of no value. And both a fraction or proportion of diet from plant, because plant is associated with low bioavailability of phosphorus, using drug wisely and encourage the patient to be adherent to treatment and follow up serially. And if the patient is on dialysis, to offer the optimum dialysis for the patients. This is one of our humble trial. It is an open label, single center randomized control trial, including 100 patients. These patients were randomly allocated into 2 groups, active and passive group. Active group means the group that was subjected to thorough education. So here we tested education, nutritional education for control of serum phosphorus in Egyptian hemodialysis patients. In this, an open label, single center randomized control study, we found that nutritional education can help in controlling the serum phosphorus level in hemodialysis patients without causing derangement in the nutritional status. It's a very important point. It seems that we need to improve the healthcare system to have the goals of 2021 World Kidney Day theme, living well with kidney disease. My strategy is to enhance education for both doctors, nurses, and patients. These are the triad responsible for the optimization of management. We should be careful. We should indulge the patient actively as a shared decision making and in the treatment by education and others. And for doctors, a doctor is a student until his end. This is, I am believing this statement. We should continue learning through our life, and through our journey in this life. We should every day we should acquire new knowledge. And I think one of the very important principles in doctor education is to follow their patients by their heart. I should stop here at this point. Thank you very much for your attention. And if you have any concern or any points, please, especially for the scientific contents, especially write your comments on the video, and I'll be happy to receive them and to reply to your questions. Thank you and goodbye.